we're now live. So let's go ahead and introduce ourselves. Why don't you go ahead, Rosa? Who are you and what do you do?
All right. Hi, my name is Rosa. I'm a former midwife from Peru. I'm a nurse and also a lactation consultant. I provide support now working in a breastfeeding clinic to all the healthcare workers in the resort of the island of Montreal. And during the pandemic, it was Laval. It was the Far East, Far East, and South Shore as well. So I work along with family doctors, and we try to address the multiple issues that come in the clinic in a multidisciplinary team. Most of the time, we don't have chiropractors or osteo in the clinic because it's a family medicine clinic, but I do refer to most of you guys because there are problems that require this body work. And torticollis is the most frequent, so that's why the importance of this. And so this is the part that I was very interested in. So proud to do this live video.
Yeah, absolutely. You're right. And I think sometimes, unless we have a really lactation issue where we know we need to get into the lactation consultant, and that's been recommended, we don't always notice the more like subtle signs that there could be a torticollis. And we'll talk a little bit more about like what causes that in a moment. But from my perspective, it's often things like, babies feeding on maybe on one side, or you notice, I see this in people's photos on Facebook all the time. Every photo they post, baby's like this.
Yeah.
And especially if it's your first baby, like you have so much that's going on in your mind. You're so busy, you're tired. There's so many new things to adapt to that you might not notice these things, or even like we'll talk more about that in a different day, but like just different like postural asymmetries. So I'm Dr. Natasha Hayden. I'm a chiropractor. I work a lot with prenatal, postpartum, and pediatric clients. And I just really found at some point that a lot of women, they're not necessarily supported very well, especially in terms of like physical medicine throughout like birth and postpartum. And it's just such a stressful period. There's just a lot that you're going through. And so we just like to make sure that like if both mom, baby have really good movement and mobility. Yeah, it's just really important stuff. Okay. So torticollis, what is that? I talked a little bit about how we might notice that there's some positional or postural things that we're noticing, side preferences. What's happening is we're having swelling in the sternocleidomastoid muscle, the SCM, right in the front of the neck. And we start to get some scar tissue that's forming and tends to lead to that turn in the head. So this can happen through birth trauma, through the labor and delivery process, because sometimes it doesn't go quite as smoothly as we hope, as Rosa can attest to. Sometimes this also happens even before labor and with intrauterine malposition. And I think you had a little bit that you wanted to share even on that. Like, go ahead.
So this was something that I had a personal friend of mine. She's a nurse as well. So she was pregnant. She had a baby. And, through that process, as nurses, we work and everybody, until certain amount of weeks. But she kind of stretched it to the week before the delivery, basically. And she was on the third trimester experiencing back pain, sciatica and so on. And she was going to a chiropractor on a weekly basis. And, she was coming off with these funny tapes, and they put
that's very popular with patients. Yeah, the taping.
So she showed me one day of her belly. She has like full of tapes, and I was making fun of her anyways. But the amazing part was that it was working. It actually helped. And she herself, it was she's a tiny woman, and her partner is like super huge. So the baby was huge for her. And we were afraid that, she may go into a C-section or something like that, but everything went smooth. The position was very well corrected for the baby. And, it went like super smooth in a scenario that we as nurses experienced it in a case room where like,
Yeah.
like, prepare for the worst, just in case. But this was a very like in my face situation. And I could see the work that, yes, it does have a definitely impact.
Absolutely.
As in case room, as a former midwife too, so I have the understanding that when the babies are going head down, babies go into a position that is called synclitic, which is even position, head down, and that's a perfect position that we call it, anatomical. But then sometimes we have this position that the head is a little bit asynclitic, so that means the head is a little tilted to the side, so then it forces these muscles to be on one side, which is the congenital torticollis that I read about it. And the babies naturally come out with that tension, and of course they have preference and difficulties over one side, and this reflects on the fact of the latch, and also reflects on the fact of the baby doesn't like this boob. It's not that doesn't like this boob, it's because it has a tension on this boob on this side, that when you put it on this side, the baby has to use this muscle, but he can because it's under tension already. So then there is a bad latch, then there is pain, and the baby's not emptying the breast correctly, and then it's leading to other certain problems. Then this is something that should be addressed at the correct time. So that's why it's important to address it in a multidisciplinary team, because one without the other, yes, you can achieve something, but you're not going to achieve the normal situation per se. So yes.
Yeah, absolutely. Like multidisciplinary, my goodness, didn't sleep enough last night. Multidisciplinary approach is really great, because there's so much that I can do in the clinic, but I'm not a lactation consultant. So it's just so great to be able to work together and really just brainstorm, and because even when there's issues with breastfeeding, there's usually a lot of even stress and anxiety that comes with that. And it's just really good to have this team-based approach, so that regardless of where the breastfeeding journey takes you, as a dyad, we can support you through that, right? Because it looks different for everyone, and every baby can look a little bit different. I think we're going to end up talking about preparing for pregnancy at some point. Because definitely, I got tired of people coming in and thinking it was women coming in and actually a second or third pregnancy, and they go, oh, I didn't know I could feel this good and be pregnant, because they would just be told things like, you have to wait till you have your baby, and meanwhile they're dragging their leg behind them, or they can't sleep. And one more recently that I was seeing during the pandemic, actually, she's like, wow, I didn't realize I had no patience for my other kids and my husband, and suddenly I'm a little more calm at home. And had a really nice recovery too after pregnancy. Yeah.
Also because when you have pain is considered stress. So when you have a stress, you cannot be yourself. So if you remove the pains, and then you can be yourself also.
Absolutely.
Right? So it's one without the other. And yes, I agree. Especially in the third trimester, especially on the last weeks of delivery, that's when they have all the mystery. The baby is taking so much room. It's very uncomfortable. And like I said, this was the case with my friend, that she was like, oh my God, working like every day. We were going having lunch, and I was looking at her and said, I'm afraid that you pop at some time. So I'm going to carry on gloves, the sterile gloves, whenever we go lunch,
Yeah.
So it was things like that, as a joke, but she did it fine. I was amazed the fact that she was extremely big, but she was comfortable. So that was something that I was like, wow. Boom,
Yeah, we see that a lot in the office too. People come in and they're like, my colleagues don't understand why I'm still at work and I'm still swimming. Not so fast, but I'm still in the pool. And because that's for me, that's my biggest goal, is to keep you active. We're going to slow down and change a few things, of course, in those last few weeks, but to keep you active, and ideally to have you sleeping is with at least 7-8 hours if we can, because that's a big complaint that comes in too. Right, we just have so much to talk about. You already addressed impact though? We're kind of repeating ourselves too. Sorry, everyone. We thought we were talking live and made a mistake. I think you addressed impact already. Did you talk about uneven molding, the craniosacral deformity that happens?
Most of the time when we have the torticollis, this is something that I have seen in the clinic, and I use the clinic also like a place to observe and target situations, and because I am working with residents and medical students, I have nurse practitioners, I have nurses as well that they're coming, so I have to make it very educational appropriate. So I am implementing new tools, I am implementing a lot of facts here there, so then when I explain it to the doctors and the residents, they are getting they're very resume and factual, and they can apply it. So, there is something that I keep on reminding the doctors and nurses, whoever comes at the clinic, if the baby have a small chin, so the latch is not going to be for sure okay, because there is a disparity. So normally is the latch, the baby mouth with a normal chin development, so then the baby will do this. But if we have a recessive chin, so there is always going to be a difference, and then there is always going to be that a little bit of pain. But as the article I was reading here, it was saying that underdeveloped or recessive chin, it might be hiding a torticollis there. So an undiagnosed torticollis. So then the necessity to work. And true to the matter, I have seen a few cases where I send them, I say, listen, we have there is no point on doing a surgery at the moment, but we do have, tension here. When I adjust, I feel the tension. So then I recommend you to go to see an osteochiro, whomever you want to see, and and go and do body work, because I feel tension here. So I'm feeling there. So there is going to be extension. And as the baby is using the muscles the way they're supposed to do, we're giving time for this also to grow.
Absolutely.
I'm seeing progress on that sense. And yes. And the other part is also when I got babies that are a little bit older, like a month or 2 months, and they have torticollis, and I can see the uneven molding on the head, that one side is flatter and the other one is roundy,
bald spots.
Yeah, so exactly. Yeah. Or I have seen only once in my life a baby that had torticollis in both sides.
Yeah, that's quite rare.
In the molding, the head is usually, because the baby is moving, so the head goes back to roundy. This baby was flat like this, a cone, like at the birth, basically.
Yeah,
so
absolutely.
That led me to, okay, this is something else. So this is the part where my expertise goes, and I call the doctor. I say, you need to come here, you need to assess this baby, and we need to send a referral elsewhere. So at that point, we send them to neuro, we send them to a whole, like the clinic, it's the opening for evaluation, and I am the one who does the full evaluation first. And then if we have a problem, doctor comes, they do their own evaluation, and if we have to do multidisciplinary, then we go for it. So
yeah,
that's the number one thing in our clinic, multidisciplinary approach, big time.
Oh, absolutely. Because there are times when it's really it's not coming from the tension isn't actually because of scar tissue. There can be different neurological issues or something coming from the brain. And that's why we really need to have this whole team. Like the first thing I'm going to ask if you're in my clinic, because I'm going to be, does your pediatrician know that this is an issue, and what did they have to say about it? Just to make sure that we're all on the same page and we're not skipping steps, as it were.
And true to the matter also, I know you're coming from a different province, and here true to the matter is that I'm working here 10 years, and in the past 2 years, I heard more about chiropractor and osteopaths. I quite frankly did have no idea what was that. I'm going to be honest, and as I was being asked, so I'm like, I have to read because I'm being asked, so I need to know what I'm saying, so I went last year to a conference, and we have the Society of Chiropractors there presenting specifically that the impact of tension, the torticollis, and the breastfeeding. And also there is an association with not necessarily torticollis, but tension in the neck, led by a baby that is tongue-tied. But most people say tongue-tied, torticollis, so we solve the tongue-tie and we don't need to do anything for the muscle. No, we have to do both together, it's one by one. So that's something that it was very well understood. And also the practice of the chiropractors, osteopaths in newborn is not so well known. So that's also a little bit of a resistance there in terms of we should work with you or not. So same thing I will say for OBGYNs, the information is not fully shared. So that's something that perhaps at some point it has to be informed, I guess, right? But I have seen success in the multidisciplinary approach with you guys, and I am so pro for that to continue happening.
Yeah, no, absolutely. And I think too, especially, I have a love-hate relationship with chiropractic videos that surface on social channels because I think it looks scary as hell. Yeah. And so for babies, like we're so gentle. I do craniosacral technique, and that's really the one that's focused in
Yeah.
reducing tensions in like dural tissue, fascia as well.
Mm.
And the pressure that we use for babies, it's like the same pressure you use to check an avocado. It's so gentle. We're not doing any rotational forces.
Yeah.
Gosh, I think it's until they're 12. Like it's really we modify everything based on where they are in their development, like their spinal development. It's super gentle. Usually babies really love being adjusted too. And we're going to work with you as well to make sure that you have a good series of stretches that you can go home and work on between our sessions, because it's, consistency at home with torticollis is really the key. And so I have some really nice ones that are usually like they can be fun to actually do with baby rather than, I know we talked a little bit about how some of the ones that we do have to do after a revision, tongue tie, can be a little stressful for mom and for baby. So I would definitely say that, this is, I think, another topic for another time, but if, whether it's torticollis or, someone's told you to have a tongue tie revision, I start with body work. So important. It's best to make sure that if there's tension there, it's all worked out and removed before we go through and do the revision. Because it might even be that the body work is enough. Just depends on what's going on. Yeah.
As personal experience, I have seen that once torticollis it's removed, the latch improve. Of course, if there is not tongue tie. Most of the people that comes to my clinic is tongue ties, latch problem, mastitis, and so on. So whenever there is a mother that is experiencing pain and blocked ducts and so on, but it doesn't necessarily relate to tongue ties, so I still do the full assessment. And yes, it's a latch problem, and everybody's looking for that perfect latch that doesn't exist. So I want to pass that message. Doesn't exist. It's an adequate latch, and an adequate latch without transfer of milk doesn't do anything. So you can have an adequate latch with a proper transfer of milk, or you can have an adequate latch with no transfer of milk. So the point here is transfer of milk, because if this baby is not getting the milk, so then the rest is not simply important. But if the baby has restrictions, of course, the jaw extension is not going to be there. It may have the lips out flanged, but then it's not able to do this. Therefore, the suction is poor, the movements are poor, and the transfer of milk is poor. So then that's something that is mechanically affecting the whole process. So that's why the importance of working there. And I always say, I always work in pair to pair. It's rare. It's very rare that I go and I say to the mother, you're going to do this, you're going to take the baby to do body work, and you come back in 2 weeks. It's rare. But I have done it too lately, because there are some more tension and so on, especially with babies that were having problems, and because I couldn't see them early, so they are non-latching. So that adds on a different, because of the pain, they decided to exclusively pump and then feed the baby with their own milk, so, but those are things that need to be addressed. And yes, I agree 100%. Before even doing a revision, this baby needs to achieve its maximum by doing body work, for sure.
Yeah, like you might as well just rule that out before, because revisions are good. We'll probably talk about a little bit about that too, because I think sometimes what I see in my practice is people that are more naturally minded tend to come to me. And I actually sometimes have to very gently encourage them to go have the revision once we've done the body work, because they think it's this big scary thing. And especially with the lasers that they use these days, I had one done in my late 20s. So we can talk about that another time. It should have happened when I was a baby, but that's like, I have a big story on why it's good to tackle these things much sooner than later.
I agree.
And definitely in our clinic too, like in our first visit, which is quite a bit longer because we have a little more to go through and we're teaching you a few things. Often I'll just let mom feed baby before they go, because it's time for that. And even just after the first session, they're like, oh, that's already a little bit easier or a little less painful for them. And it's just these multidisciplinary approach. I think that's really the future of medicine, is working in teams and putting egos aside.
I agree.
Yeah.
300%
yeah.
Yes.
Absolutely. Like
I am so pro multidisciplinary, you know, because everybody has their expertise, and within that expertise, we need to provide the best for the client. You know, in the end, it's multiple disciplines coming to one goal, and that goal is serving the population to its best and get them to where they need to go, you know?
Absolutely. Yeah, that's always been a tenet in my practice, is if I can't help you, I will find the person who's best suited to help you. And that's part of my training. And I want to make sure that you have the right tools and right resources.
Yeah.
It's so important. I get a lot of the people that fall through the cracks. So yeah.
It's the system, you know? So that's why I always say to the resident medical students that I come at the clinic, I say, I'm not expecting you that after 4 hours of seeing what I do, you're going to be an expert, because it took me 90 hours of learning. It took me 6 months to be at the level that I am of expertise on a daily practice, you know, and after that, and I had to be mentored by somebody who was on the expertise that I have right now. So it's not just like you can go and do assessments and just like that. No, it takes a lot of teaching, and that's the lack of information too, because you know, most of the mothers, they come in such a distress, and after I sell the problem, because I have this whole bunch of information collected, and I was like, okay, your problem is this, and sometimes it's just a latch adjustment, and they're like, how come the nurse didn't tell me? How come my pediatrician did? How come the family doctor did? How come the nurse at the case room or the postpartum? So I'm like, and that's what I explain, and I say, because I am the specialist. I am the one who has this expertise. And, you know, this is the part where we have to work like this, you know. So, yes, I agree. And doctors, too, are very pro into, you know, work with me. And I'm basically on my own until I need a further assessment. And they are coming in. And they are coming in to do the surgery. But I'm the one who does the teaching after, before, and after. And, you know, so that's the whole multidisciplinary approach that is best. The idea for doctors, residents, and students that are coming into the clinic is to understand that there is this specialty that we can serve the population, and whenever you see this, you have an understanding that something is going wrong, and you can refer to this clinic, you know. So
yeah,
majority of of referrals too are coming are from the CLSC, but then we have residents in the clinic that they already graduated, they have their own practice, and they're referring to us. You know, like all customers. But yeah, so that's the point.
So it's probably good to clarify then that if someone wants to work with you, they don't need a referral. They can just call you directly. That's right, eh?
No, because it's a health service.
In your private practice, though?
In my private practice, yes. I have my website to prevent a conflict of interest. My private practice doesn't have my name. It's in a different name. You know, Lactation, Maman Cigogne. And so then they contact me. They go directly through the website. They can book at any time. And so I always, I'm happy to help them at any time. And this is a private service. This is at their home. So they don't need to move and come. In the public setting is that you need to come to me.
Exactly. Okay. So it's just to clarify that then, because I've had patients that you've sent that have gone either through the CLSC or through the lactation clinic or through your private practice. So, and right now I think people are kind of like to stay at home where they can. So if you're at the lactation clinic, you just might be lucky and have Rosa, but otherwise, like, you are available for home visits if that's what someone would prefer outside of the public sector. And then just to, I guess to clarify, like, if someone wants to see me, they absolutely don't need to have a referral of any kind.
That's why I had you, and when it's from my private practice, I send it to you. But then at the clinic, I got a call from somebody requesting for referrals from the clinic, and I'm like, that's another paperwork that I need to do. whole bunch of stuff. So anyway,
Yeah.
after discussing it all, so we decided to do a quick note, like I find this tension here, that go, so nothing formal, like I am when I sent you in the private setting, because I have my time to do this, but yeah, I mean, it's getting there. We're gonna try to facilitate the communication too, and the clinic also. It's mainly referrals, again, from the healthcare workers at the clinic, and also because we have to work with dentists and so on. Sometimes patients don't want to wait, and sometimes patients, they go and do it quickly and come. So sometimes I do receive referrals too, and I'm trying to encourage dentists that are not having their patients seen by an IBCLC early on, to refer to the clinic the least, or strongly recommend to see the patient should go along with an IBCLC prior to the revision and after. But if it's late, I mean, do it after. So that's the part. But it's important.
Yeah, the interdisciplinary approach.
Yeah.
Alrighty. I think we've covered torticollis and a few other things at this point. If you're listening either live or you're going to catch this later, I think we're hoping to connect once a month and just talk about different topics in like breastfeeding, like prenatal. Yeah. So, I mean, I don't know if we've decided what we want to chat about in September. But if you have anything that you're curious about from like perspective chiropractic, midwifery, because that's certainly your background, as well as like labor delivery, lactation, feel free to just make a comment. Like if this eventually gets put on my website, I'm so slow to do that. You can email me. But yeah.
I'm busy with chiropractic. I'm busy with work, and I have to move soon to my new home. So it's like.
There's always something else to do, isn't there? Yeah. So anyway, probably a little Facebook comment if there's something you really have a burning question or something you'd like to hear more about. I think we were a little scattered today, but that's because we repeated ourselves because I didn't put it live. So be a little more organized next time for sure.
I think I saw that you have a blog with articles, right?
I do, and I still haven't posted any of the recordings I did in April for healthcare at home. So that's my goal to have done by September. Mm-hmm. So it's definitely going to be saved to Facebook though, for sure. Mm-hmm. And I want to put the videos through Rev to add subtitles, because that's just a little more accessible. And then post it to the blog. But natashahayden.ca. I do have a lot of topics on my website there.
Exactly. So I have also a blog in my website. I don't do it as often, but I have some articles talking about ankylosing, milk supply, and so on. So it's general information. It's information that is out there. I'm just making it short, sweet and short, concise and up to date as well too. So yeah, you're welcome to join me anytime. Lactation, Maman Cigogne.ca.
All right, great. We'll make sure we share that to our page too today. All right. Thank you so much, Rosa. I think we're going to end our live now. And I guess we'll see everyone in September with a new topic to be decided.
Yes.
Right. Have a great day.
Bye.
Bye.